Hi, good evening, everybody. Thank you very much for joining us during this Willows Academy webinar during this really rainy Wednesday evening in Leicester. So just before we get to the actual nub of the conversation today, our masterclass in digital primary care, I just wanted to go through house rules, if I may. So if you could keep your cameras and microphones switched off through the course of the webinar, and hopefully what we plan on doing later is posting the webinar onto the Willows Health YouTube channel. So Kavita is going to put the link of the Willows Health YouTube channel on the chat just in a bit later. So on there, you'll find our previous two webinars. During our first webinar, we had Professor Bennett join us, who's chair of the British Thoracic Society, and he spoke about the challenges of coronavirus on the front line. Last week, we had the paediatric team from the Leicester Royal Infirmary join us, and they spoke about COVID in children. If you require a CPD certificate for either of these discussions, then please will you email the address on the chat, and we can actually get a CPD certificate sent out to you. What we plan on doing is having a discussion and a Q&A segment after the presentation by our speakers this evening. So if you could put or post any questions on the chat, and I'll try my very best to honour them. So let's get on to the topic and subject matter of the discussion this evening. And again, we're talking about digital primary care, and we're going to be talking about a masterclass in digital primary care. COVID has changed the landscape of how we deliver primary care, perhaps forever. A crisis, a pandemic such as this, can breed innovation though. And if we look back in history, some of the greatest innovations of all time were developed during times of crisis. So if we take Sir Isaac Newton, for example, he found the law of gravity during the bubonic plague. The basketball, the humble basketball, was developed during the recession in 1894. If we look at the famous book, The Art of War by Sun Tzu, it says that in the midst of chaos, there is opportunity. And there is opportunity within this pandemic. And it could change how we work forever, and in turn save thousands of lives that we have lost to this pandemic already. It's times such as this that we need our collective creativity the most. It's really pushed how we consult into the future, and so we are now at the digital realm. And I've got two fantastic speakers talking about the topic today. We have Professor Mayur Lakhani, who perhaps needs no introduction at all. He is the past immediate president of the Royal College of General Practitioners, the current chair of the Faculty of Medical Leadership and Management, the current chair of West Leicestershire CCG, and the previous chair to the National Council of Palliative Care. He was also awarded a CBE in 2007 for services to medicine. We also have Dr. Minal Bakhai, who is a national clinical lead for online consultations, an expert advisor to the National Institute of Clinical Excellence, and NHS England Deputy Director. So thank you so much both for joining us today. I'm going to pass the floor and mic over to Mayur, who's going to kick off the discussions for today. Mayur. Mayur, your microphone's on mute.
Hi everyone, and welcome to this webinar. Can I begin by thanking Tariq for hosting this, what I hope will be a very interesting and informative session for you. Minal and I are going to do a double act. Minal is going to commence with an overview of digital first primary care with the models of care, some evidence around it, and what I think is a brilliant case study of how it can be made to work in practice. I'm going to follow that up with some information about the standards for remote assessments and to show how it can be done safely and securely, and also to share some tips that I've learned during this pandemic of working safely, and maybe put the context of the LLR work and what this means for us in LLR, not just in general practice, but as a system. So I'm delighted to collaborate with Minal. Minal is a great friend friend of the Royal College of GPs. She and colleagues such as Jonathan have at the college have developed this tremendous document on standards for video consultations issued by NHS England and the RCGP, which many of you will be familiar with. So without further ado, let's start the webinar. And can I invite Minal to start her presentation, please? Thank you.
Thank you. Thank you very much. And thank you for inviting me to come and speak to you. So I think perhaps just to start off by saying one of the key things that we often focus on when we talk about digital is access. But I hope that I can share with you how digital has enabled benefits way beyond access for many practices. But just to start off with, if we could just reflect on our current access model. So if we could move to the next slide, please. So one of our key challenges and one of the key things that I think total digital triage can help us with is that our system is very fragmented, and therefore often the front door that the patient uses to enter the system often determines the outcome, and that leads to inconsistency and unwarranted variation in care, lots of confusion from the patient's perspective. They don't know where to go. And it also means patients are bounced around the system, leading to poor experience and delays in care. And so patients do what they feel most familiar with, which is either go to A&E, but more likely contact their GP practice. And so if we go to our traditional Monday mornings in general practice, the phone lines will ring off the hook from 8 a.m. Eventually, when the patient gets through, they speak to a receptionist. There may be some form of very basic triage, but most often the patient is booked into an appointment. And what we know is that the fastest finger wins. It's an inequitable system. And about 40% of what sits in front of us as GPs doesn't need us. It either needs somebody else in our team or another service, or actually the patient could have been advised to self-manage and not come in at all. And then it often takes some routing before the patient gets to the right place or right person or service, which leads to both a poor experience and inefficient use of resources and patient time. So if we could move on to the next slide, please. So in response to COVID, there has been a drive towards moving to a total triage way of working. And this means that every patient is triaged first before being offered an appointment. And in response to COVID, this is to protect patients and staff from the risk of infection. And while this is entirely possible to do this by telephone, and many practices are doing this by telephone, using online consultations can help us leverage even further efficiency and benefit. And this is the model that I'm going to be describing as total digital triage. And I'll talk about that a little bit more in a minute. But to enable this model, nationally, we set up a rapid procurement for all those practices that did not have an online consultation or video consultation solution available. And we enabled commissioners to procure a product within 48 hours. The assurance, the specification, the contracts were all managed centrally. Of course, they're all fully funded centrally, and that was to reduce the burden on practices and commissioners, but also ensure that the approach was robust. And part of the specification was that particularly the online consultation suppliers had to be prepared to support practices with rapid and safe implementation and provide ongoing support and training to their practices, as well as virtual training materials that practices could then give to their locum staff if they ever needed additional or new capacity, particularly if there was a surge. But we know that the deploying of the technology is the easy bit. And that in itself does not result in transformation, and the transformation is the key to achieving the positive outcomes that I'm going to talk about for patients and staff. And so nationally, we have coordinated, provided training and funded a blended team made up of national, regional and local colleagues, AHSNs, CSUs, Time for Care teams that all provide hands-on implementation support and capacity, quality improvement and technical expertise, as well as resources to practices to help understand their challenges and then optimize the use of these solutions redesigning their workflow and their care pathways, and supporting that change management piece, which is absolutely fundamental for transformation. And the feedback so far has been really positive, but what we've learned is that relationships are absolutely key. And while the teams have really enjoyed working together and learning about each other's roles and responsibilities, and working towards this common purpose of supporting general practice, it can be challenging to put aside your usual ways of working and adapt. So as a national team, we are supporting our regional colleagues to coordinate and develop substantive posts and teams within their systems that almost form an extended part of the practices and PCN's team, so a bit like your MDT, to provide that ongoing implementation and quality improvement approach, which is required particularly when it comes to digital, to see that transformation and therefore demonstrate benefit. We've also adopted a very much a data-driven approach to this program. So we've been using data to track implementation and support utilization and support regions and systems in allocating resources to the areas of most need. And while that is still in development, because the data is being refined and the quality is being improved, that's helped significantly in being able to send resources to the right places. I think it's really important to remember that many of these models are still emerging, and we are keen to capture the strengths and the unintended consequences and shape what sustainable general practice looks like by understanding and incorporating the learning. So there are multiple evaluations currently underway to understand how total digital triage has enabled practices to respond to COVID, the critical success factors for implementation, and which elements to retain in the recovery phase. But anecdotally, we know that staff have been very positive about their experience of online and video consultations. Patient satisfaction scores have remained high, and there's been a growing confidence in this new way of working. And while it's often the digital bit that gets the focus, we must remember that these are just tools, they're vehicles, and it's about the implementation. And if implemented well, they can help connect people and build relationships. And that's often a worry. Do we lose the relational element of general practice through digital? Well, the research tells us no. So to date, the research says that you can maintain the doctor-patient relationship when you consult online. You can still be empathic and personal and pick up cues through written consultations, but it is a new skill, and I'll pick up on that a little bit later. And you can also build your relationships because these tools help you design for continuity because of the flexibility that they afford you. They also help you bring together your MDT virtually to support those with more complex needs. And patients report that they find that they can spend more time thinking and detailing their concerns within their online consultation because of the asynchronous nature and not being confined to 10 minutes. And of course, as a GP, I have the time to review the information, prep if I need to, and both of these elements can help build that mutual partnership. If we could move on to the next slide, please. So, like I said, there has been some amazing innovation happening in general practice, with practices and PCNs leading the charge, leading that local change and adapting to new ways of working. And that has been hugely impressive. I think we've shown how agile we really are. And this is just a snapshot, an overview of the data. So online consultations are now live in 88% of the practices in England, with 9% implementing at the moment. And this is a step change from less than 35% pre-COVID. And video consultations are live in 99% of practices, and that was less than 5% pre-COVID. So general practice has done phenomenally in their response digitally to COVID. And I think perhaps it's important here to call out some of the key enablers, some of the key things that I think we do not want to lose when we go back to the new normal, or we go to the new normal. So having that really clear purpose during COVID, it set a direction for us, and it meant that there was alignment across the whole system, including policy, regulation, professional bodies. There was that consistent messaging and alignment of incentives. So that was great. Secondly, general practice had headspace to innovate and think about what change looked like and work in new ways. We involved all our teams, our whole teams, in the process change, and that helps improve team morale. We made decisions based on need and were proactive with the care that we delivered, and that's very different from the kind of target-driven performance management, assurance-based activity that perhaps we were used to before. And we've seen some great local collaboration and bottom-up approach to leadership. And I think that has been key. PCNs working together, fostering new relationships with acute and community colleagues, delivering care at scale in hubs, and working as high-performing health systems. Brilliant. And we've also seen some brilliant team working. We've been looking after our teams. We've been checking in with each other. We've been checking out. We've been feeling more valued, team huddles, peer reviews, again, high functioning teams. And also it's been great to see from my perspective, certain digital suppliers also really stepping up, working closely with practices to co-design solutions and to meet needs. And I hope that this is an ethos we can share across all the suppliers in our system. And also we've managed to get some of those basics sorted that we've spent ages, years on, like data sharing and getting laptops out. So we don't want to go back. And so I'm keen as a programme, particularly, that we move away from this structure of command and control to transparency and collaborative decision making. And so we are proactively working with our regional colleagues and systems to ensure there's formalised and meaningful engagement with practices and PCNs, being very clear about what funding streams are available, designing what products and support is bought collaboratively and strategically. We need to share in how we solve problems for our systems as well as how we solve problems for our practices. If we could move on to the next slide, please. So I talked about the models, so I'm just going to share a couple of models with you. And I think it's important to recognise there is no one size fits all. There are a variety of models, and these models will need to be localised to adapt to your population needs. But these are the two main models that generally practices are using. So the first is a practice level total digital triage model. So this means that as a patient, I would go onto my practice website and complete a structured questionnaire that asks me to complete similar questions to those that I would ask in practice, particularly ideas, concerns and expectations. Now, there are a variety of different products out there, and we can talk in more detail if people are interested in sort of pros and cons of different products. But in essence, these products allow patients to give the practice information about their health concern, and they can also allow them to send securely a photo, for example, of a rash, and that's done in the patient's own time and at their own convenience. And if a patient can't use digital or chooses not to, then they can phone the practice. So this doesn't cut off any other access routes. All of those other access channels are still open. So a patient can phone the practice and the staff can encourage them to use the online system. Some practice staff ask, do you ever book or shop online as an opening line? But staff will send them an SMS link to access the online service easily, or encourage them to ask a relative or carer to help them. But if patients can't or don't have anybody, then reception staff will complete the online form on behalf of the patient. So they'll take them through each question and they use it as a health navigation tool. Now, it's important to train your staff or use experienced staff to do this, so they have the right communication skills to ask these questions. But it is vital that staff take patients through this process and try to avoid directly booking patients into appointments, because patients will otherwise opt for the channel that they perceive gives them the fastest response. And so by direct booking into appointments, it disincentivizes use of the online system, but it also means workflow is more complex because you're then juggling different systems. But of course, have a few agreed exceptions, like your vulnerable patients, your frail elderly, that you do book straight in. And this way, whether you're a digital user or a non-user, you have an equitable service. And by encouraging more people to go online, you can then free up the phone lines for those that can't. And really importantly, for the practice, work flows through a single route, which is both safer and more efficient. Once the consultation has been submitted, admin staff can filter out any admin requests so they're not sitting in front of the clinician. They can flag any urgent or red flag requests. Some questionnaires may help them to do this, but many reception staff have been doing this for many years already with phone requests. And importantly, they distribute work to the most appropriate person in the team. And that may be to optimize the use of your skill mix, but also designing for continuity. So where patients need continuity, they can direct that patient to their regular GP. And so some practices use a personalized list system, others use a traffic light system to highlight which patients would benefit most from continuity or have complex needs or are vulnerable. And then this information is presented to a clinician in a way that is quick and easy to assimilate to help them decide what to do next. So respond through messaging, a video consult, a telephone, or a face-to-face. And patients from the research like it because they feel like they're getting a direct line to their clinician and bypassing the gatekeeping role of reception. But there is also no indication from the research that marginalised groups fare any worse where online consultations are routine. In fact, some patients that are traditionally marginalised from general practice, those with physical disabilities, mental health issues, presenting with sensitive or embarrassing issues, often sexual health type problems, find this far less stressful. If we could move on to the next slide. This model could also be used within a PCN or a group of PCNs as a virtual hub. So we've also seen virtual hubs being set up. And so this is where clinicians working on behalf of a group of practices will provide remote consultations. And this has been used successfully to maximise capabilities of staff across practices, manage overflow or extended access, and also maintain stability where practices have temporarily closed down. And so we're now starting to transform the operating model. Now, with this sort of model, the evidence so far shows that it's particularly appealing to smaller practices who may struggle to find the capacity to do the change management alone. So by working with other practices, they're sharing policies, they're sharing protocols, they're sharing the workforce to design the processes and workflow. And staff find that really helpful. And they've also found it helps connect them together as a PCN. So bring together that relationship. But there are challenges, as with all of these things. So technological barriers. So if you're on different clinical systems, that can be a little bit more difficult because it's not seamless yet. But also larger practices have found that they sometimes feel like they're having to compromise because they're changing their processes or their protocols to fit in with everybody else when actually they feel they could manage the whole workflow themselves. In terms of outcomes, we know that particularly with a hub, patients get a faster response. So it's great perhaps for those acute same-day type issues. We know that it's great for sharing workforce. So in Lambeth, where they run one of these, 10 to 15% of all the online consultations are managed by the PCN pharmacist that they share. That's been brilliant. They also share admin. That's also been very positive. But perhaps when the triage is done by the hub itself, they bring in more patients face-to-face because there's that unfamiliarity, that lack of continuity with the patient. So it's about balancing and again, adapting to what your population needs. But I think what is emerging is that when we start to see transformation at both practice and PCN level, both working together, then that can be a very powerful combination. Could we move on to the next slide, please? So I think this is just really to emphasize that we need to transform to see outcomes. So if we could go back a slide. Brilliant, thank you. So, no, sorry, forward a slide. Thank you. Can we go forward one more? Brilliant. So pre-COVID, we were doing most of our consultations face-to-face. So 85% plus was face-to-face. During COVID, more than 90% remote, so it completely flipped. And what we can see here, so this is data taking about 1 million patients using online consultations, is that actually about 40%, up to 40% can be managed.
Yes, got it. Yeah.
someone could go on mute. Thank you. So between 30 to 40% could be managed just through direct messaging. We can see that telephone calls are often sufficient and the use of video is very targeted. So while video is great to have in our armory, it doesn't mean that we need to use it for every consultation that we do remotely. Target use is key. It's also interesting. So on the left-hand side, you can see what patients requested from their clinicians. So when they submitted an online consultation, which mode of response they requested. And you can see that less than 10%, in most cases 5 to 6% requested a face-to-face, and everybody else requested a remote response. So really interesting to say how our patients are adapting. You know, often you hear, well, my patients don't want to use this. But actually, if you promote it and explain it to patients in the right way, they really do want to use it. And so often we also make assumptions about who can and can't use online consultations. And I'll come to some graphs in a minute to kind of debunk a few myths around that, I think. But I think what's really, really important is that these are atypical times. I do not expect us to be doing 90% of consultations remotely. And actually, we will miss the face-to-face interaction if we do that. But there is a balance. And what we know is that pre-COVID, practices that were working in this way were seeing about a third of their patients face-to-face. And they felt really satisfied because patients had flexibility in terms of how they chose to access their practice. Clinicians had flexibility in terms of their clinical approach. That flexibility meant that they could customize appointment length. So when they needed to see somebody face to face, they didn't need 10 minutes. They could spend 20 minutes or half an hour without feeling pressurized. So hugely satisfying for both parties. So it's about augmenting the traditional model of care and redesigning our care pathways, moving away from any one size fits all, using the right modality for the right person, but not replacing anything. Could we move on to the next slide? So this talks about access. So when people have been using total digital triage as triage with digital tools, most patients get a response on the same day, and often patients are getting a response within a few hours. So that's great. It does the access bit, brilliant. But actually, if we could move on to the next slide, there are many more benefits. And here you can see that continuity improves with the use of digital. So on average, continuity is about 15 to 30% in practices. And what we're seeing is continuity leap up to 70, 75%, in some cases 90% in practices. So that's really reassuring to see that actually you can have improved access and improved continuity if you design for it. Could we move on to the next slide, please? So I'm now just going to talk about some of the key principles, the sort of top tips for online and video consulting. So like I said, it's a skill. It takes a bit of experience, but there are lots of things that we already do really well. And so we shouldn't change those. So it is a consultation. Doesn't matter that it's remote, it's still a consultation. So the same boundaries and thresholds you use in a consultation still apply. Most effective way of promoting uptake of the system is for practice staff to encourage patients to use it. Patients trust staff, patients trust clinicians. They are the most valuable asset we have in promoting this system. But it is also important to make them aware and make it easy to find. So don't hide it on page 5 of the website. It needs to be prominent, front page of your website, clear banner. Practice staff and clinicians should encourage use of the system when they interact opportunistically with patients, and having that consistency in messaging is really, really important. It's important to ensure that there are routes to support non-digital users and that patients are aware of these, and that all staff are consistent in following that total triage process to make sure it's equitable, with the exceptions agreed by the practice. Remember that you're not seeing the patient and you're not speaking to them, so you still need to remain curious and vigilant, and if you have concerns about safeguarding, then convert the remote consultation to a face-to-face assessment and use the data, because these are data-driven approaches. They give us better data than we're used to. So use the patient feedback, use the data that you get back from these systems to understand your demand patterns, to match your capacity to periods of high demand. So one of the key concerns is that this will open the floodgates. I'll get swamped. All I'll get is lots and lots of requests from patients, and I'll just sink. And we haven't seen that at all. Actually, demand is really predictable, and demand doesn't significantly increase. So what we see is that about 20% of unmet demand, which is what we have on average, is what we see the increase being. But actually, because we're redistributing that 40% of work that sits in front of us that doesn't need us, it balances out. Demand is highest on Monday and Tuesday, like normal general practice. 2/3 of online consultations come in by midday. So we need to then change the way our capacity is set up to be able to meet that demand. If we could move on to the next slide, please. So conducting online asynchronous written consultations. So these are the key things that have been pulled out of research, case studies, and I've been online consulting for 6 years. So these are some of my own experiences. So it's really important to provide clear advice to patients on your practice website about the rules of engagement. So how do you use the system? What happens behind the scenes? Who's going to see it? What to do in an emergency? When to expect a response? What time your surgery is open till? Because an online consultation will allow people to submit a response at 3 in the morning. Just need to be clear, you're not going to be there at 3 in the morning. Do reassure people that they are still accessing a clinician. This is not a barrier to accessing services. Actually, it's lowering that barrier. But the system is secure and private, and it's an NHS assured system. Do acknowledge when the patient sends you a request and let them know it's been actioned. You can automate that. You can send them a preset template. And explain that the mode of response isn't automatically online. It might be a face-to-face, it might be a telephone, it's personalised to their needs. Do pass that consultation to the patient's regular clinician, again, enabling continuity where possible. We know that those outcomes are better when the person knows the patient. You're less likely to misinterpret what they're saying. Decide how to respond using the modality that meets their needs. Think about, are there any red flags? Is it clear to me what the patient wants from their consultation? Have they made that clear? What are their ideas? What are their health beliefs here? And am I familiar with this person and their condition? And one of the great things about it being asynchronous is you can ask somebody, you can Google it, you can take peer-reviewed decisions because the patient isn't just sitting in front of you. So actually what we hear from practices is it's been really great because I've been able to have that case-based discussion right there in real time. So really helpful both to educate colleagues, staff, and improve your own learning, but feeling that kind of team working approach. You're not working alone. That hive mind. If we could move on to the next slide. Thank you. So relate. You can build that connection, but don't try and overthink it. Write in the tone that you would normally use. Don't try and conduct the perfect message. It doesn't have to sound perfect. Be personal. Write with emotion and empathy. Patients can still express concerns indirectly. You be alert to their written cues and respond to those. And have a plan for dealing with misunderstandings. Just pick up the phone. If you think that, that the patient or yourself are not really getting anywhere, it's turning into quite a lengthy consultation. In terms of when you respond, summarize what the patient has written to you so that you're on the same page. You have to trust the system, so don't repeat the history, but clarify, check nothing has changed. Use preset messages or questions and then personalize them to save you time. Because you can't see somebody and because you can't hear them, share your concerns. You've got to be explicit. And again, you've got to clearly justify decision making with them. If you could move on to the next slide. Give the opportunity for patients to ask questions or to explain anything again. Be specific about what happens next. Safety netting, again, is really important. So again, explicit instructions the patient can refer back to. And that's one of the great things, the patient can refer back to them. Add links to advice on nhs.uk. So you don't need to type out all of the information. Patients can use online consultations for following. You can use online consultations to follow up. Make sure you code properly for your data, and you don't need to work in isolation or alone. So buddy, mentoring, share your concerns, join a community of practice, have regular debriefs, and use your MDT. If we could move on to the next slide. So I'm just going to finish up very shortly. So video consultations, Mayo explained we'd written some guidance on this. So just a few top tips for me from video consultations. You can't always see everybody that's off camera, so make sure that you introduce everybody in the room and the patient does. Take the patient's phone number in case the video link breaks down so you can follow up. And if the connection is poor, don't try and persevere because you might miss out some important information if there's a technical interference. Confirm the patient's location. They might not always be at home. If you're going to look away, signpost to what you're doing so that it doesn't look like you're not paying attention. People find it hard to look at the camera. That's not a problem. Maybe start off just looking at the camera so they can see you. Try and speak when you're talking, look at the camera, and when you're listening, looking at the screen and the camera. But if you position your webcam so it's landscape, they can see your face, your facial expressions, your hand movements, gestures, you're engaged, they'll be engaged. Being able to visually assess the patient in their surroundings, their own home, really helpful, lots of cues. And in terms of remote examination top tips, if you want the pulse rate, ask the patient to tap it out and count. If you want to check the respiratory rate, ask the patient to place their hand on their chest, makes it easier to see movement. There are apps where you can tap, so it counts the respiratory rate for you. If you're worried about acute abdomen, brilliant emergency consultant told me, ask the patient to blow their tummy out and cough. If they can do that without grimacing, they don't have peritonitis. And when you're looking at rashes, still pictures give better resolution than video. And lots of people have home monitoring devices now, so get them to use them. And if they don't know how to do it over video, show them over video how to use it. I've got lots and lots of top tips in the guidance that we've written, so just please have a look. If we go on to the next slide. So this just demonstrates that all patients, doesn't matter what age, can use online modalities. But we know that the older you are, you're more likely to use telephone, and the younger you are, you're more likely to use online. And if you're a parent, you're going to use online for your children. If we could move on to the next slide. And this is a case study. Thistle Medical Centre in Peterborough. They have 80% of their online consultations take place in languages other than English. We know that patients who are non-English speaking often prefer to write in a consultation. They find that easier. They can get their relatives to help. They can take their time. They've had more than 2,000 plus online consultations through a month and 150 to 200 daily hits to their website. Sorry. And what they've done is they've made a concerted effort to reach out to their patients. So they've produced materials in the languages that their patients speak. They've used social media to reach those patients. They send SMS text messages to patients in the language that they speak, and they're lucky enough to have staff that do also speak numerous languages to support their patients. But really, I guess the point is that you can reach people, but you've got to make the effort to reach them within their own community. And if we could go on to the last slide, this is just outcomes. So we did a big piece of research pre-COVID about meaningful outcomes for practices and patients, with practices and patients, about what would be important for them to monitor in terms of impact of online and video consultations. And so these are forming the spec that we're giving all of the suppliers, plus other outcomes, so that this data can be provided to practices in near real time to help measure impact. And you can read about what those things are on the slide, but I think I'm running out of time, so I'm going to stop there. There are some resources on the next slide, I think, but I'm going to hand over to Mayor now.
I'm just going to just summarize that with my presentation, please, if I can have that on just for a couple of minutes, and then we'll go on to Q&A. So I know that working remotely, causes a lot of anxiety, and myself, as a fairly experienced clinician, I felt some of this was out of my comfort zone. But to reassure you that actually this is about being a good GP, it's all the skills that you use every day. And the College of GPs, together with the College of Emergency Medicine and RCPCH, the pediatricians, we've set the standards for assessing quality in remote consultations. So it's described here, and this is how a consultation would be assessed remotely. Essentially, the key outcome we're looking for is a safe outcome. We know there are lots of things that you can do. There are options, but if you follow this, it's actually, which is what almost every GP does every day, it's a very, very powerful support for you. Next slide, please. These are some things that I've learned in my shifts. I've done about 25 shifts for the National COVID Assessment Service. These are for GPs who are returning to work or who have volunteered to do the work in the evenings or midnight or early mornings. Essentially, you're dealing with a condition that we don't fully understand, where the information is changing. So you need to have all the information at your fingertips. So I have a file on my desktop with all the latest government guidance about testing, about isolation, about clinical features. The key thing we want with remote assessment is that it adds value to the consultation. I think it's less good if remote consultation is used to pass things on or to transfer risk to other services. I think you have to try and provide solutions and match it to the reason for the call. Some other things I've learned, be clear about red flags, what's called the immediately life-threatening protocols. But you need to speak to the patient first. That's absolutely, or at some stage during the consultation. Something else I learned was, are you alone? So if a patient is alone, giving self-care advice would usually not be a safe outcome. So a frail older patient with possible COVID symptoms, asking them to buy paracetamol in the middle of the night or, to ring back may not be the best thing to do. Instead, you should be organizing daily phone calls, particularly if they're shielding. There's particular care needed for children. I would say the most important thing is around empowerment and shared decision making. So a great question that I know many of you use: what were you hoping I could do for you today? Why now? And safety netting in terms of detail rather than I'll see you if you know better. And a great thing that I learned from a trainee actually was around closing the consultation with PHWP, patient happy with plan. So this slide addresses this thing about I'll be sued if I do this, if I don't see the patient. Actually, you can consult safely. Next slide, please. This is really just in COVID-19, there's 3 things you worry about in remote assessment: pneumonia, pulmonary embolism, and sepsis or cytokine release syndrome. I won't have time to go into that, but the slides will be available for you. Next slide, please. I strongly recommend this. We were going to do a section on remote assessment of children. I think extra care is needed, but it can be done. And I'd strongly recommend this website for you, which has pathways and safety netting that you can SMS patients, parents as well. Next slide, please. Next slide, please. Thank you. So finally, just to close on this, I guess I want to pose the question about how do we move forward in LLR. One of the things we've discussed as a system is what can we learn from COVID-19 and what can we take forward. I mean, Minal's given a very powerful demonstration of how a digital first approach increases access, improves continuity, works in deprived communities, supports BAME communities. It's not the only offer or the only answer, but it's part of a range of access and consultation modalities, I think it can be very great. And I know the hospitals are very interested in this. For example, diabetes specialists, mental health specialists have found more compliance with consultations working digitally. So digital first in LLR. I'd like your help in embracing that so that we don't go back to the old days of massive workload, access that we can't meet, and overwhelm doctors. So I think this is all about helping patients, helping doctors, and helping the healthcare system. So I'll stop there. Thank you, Tariq.
Thank you, Mayor, and thank you, Minal, for a fantastic presentation. I think, Minal, particularly, your discussion on the operational and strategic parameters by which we're redefining primary care was really useful. And I think the thing I take away from that is the fantastic change management up and down the country. And I think us as doctors often aren't trained in change management, and often we have lots of barriers to actually changing how we work on a day-to-day basis. I think what we've demonstrated through this pandemic is doctors are really good at managing change, and we've done it in a matter of days. I mean, in our practice in Leicester, Willows, we've had 44,000 patients go from a traditional face-to-face consulting methodology to a digital first and telephone triage within a week. And that has taken a lot of hard work, but I think actually it shows that as clinicians, we are very adaptable to the needs of our population. I think also some of the other sort of items we had already alluded to is it's fantastic to see that the research is showing improved access, continuity, and perhaps even outcomes, whilst maintaining a traditional ethic in terms of the quality of care we're delivering to our patients. And of course, data is king, and I'm hoping that as the months roll by, we'll be able to collate even more data, have more research on this topic, and that will hopefully be able to empower us to manage this change further. So Mayor, any thoughts on that at all?
No, I think it's I think this is a really important debate for us. I think some people are concerned that virtual care and robots and artificial intelligence may replace the doctor. Nothing is further from the truth. A very famous doctor called Eric Topol has written that actually embracing new ways of working can allow doctors to spend more time with their patients and make us more human and make medicine more human, because we spend a lot of our time looking for things, looking for results, looking for a letter. Imagine if all that was done for you. And this is happening now. So, but I can say I'm proud of the leadership that GPs have shown and the hard work that they're doing in LLR. So very interesting, and I'll be interested to hear what more comments or questions that people have. I know we're running a little bit behind, but I don't know how Tariq wants to manage that. But
I think I can take the questions off the floor perhaps initially. And one of the questions was safeguarding, something that's really significant during the pandemic. People are locked up in their own homes. We know that cases of safeguarding perhaps will be increasing through this pandemic, and we need to assure ourselves of safeguards. And one of the questions Dr. Prasad was asking was about chaperoning, and how do you safeguard ourselves within a video consultation, and when should we be seeking a chaperone?
So I would say use a chaperone in any situation that you would use a chaperone for in a face-to-face consultation, particularly if you're doing a remote intimate examination. That's very important. There are things that you need to consider, like no one else can see your screen. You're in a private area when you're doing the consultation, that the patient as well is in a private setting, because they're often in their home, so there are other people around. Does the patient want anyone present on their side when you're doing the examination? But equally, to protect both yourself and the patient, you would need a trained chaperone on your side. That might be a virtual chaperone, or it might be somebody, if you're in clinic and you're doing this, then that they're available, but they should be visible to the patient on screen. So not, it's not somebody hidden. You do need to also consider whether that chaperone has the experience and competency to chaperone in a remote environment, and because it is different to a face-to-face setting. And the GMC have written some really useful guidance on internet examinations and chaperones. You would still follow that same principles. And we have written, and it's due to be published soon, a very big cross-organisational piece with the Royal College of GPs, physicians, the RCPCH, the Prime Prosecution Service, reviewed by the police. I mean, the list goes on, the MDOs, but really talking about intimate image sharing remotely, because it could be photos, it could be a video examination that goes through some of those key principles to consider to safeguard both you and the patient, but also enables you to provide care that's in their best interest and meets clinical need.
Thank you, Minal. Really useful information there. And I think we'll wait for formal guidance, as Mayor has suggested, also on sensitive examinations. Now, also, I was really interested to hear, Minal, that you've been consulting digitally for the last 6 years, and you've been in the future for quite a long time, it seems.
Too long.
And one of the anxieties about consulting digitally is perhaps the risk digital consultations have on the individual clinician in terms of the conditions they're managing. And there is clinician anxiety about getting the diagnosis wrong or having an increased risk of medical legal sort of proceedings thereafter. What's been your experience, Minal?
So touch wood, no problems medical legally. But in terms of what's the position, the medical legal position, so I've worked very closely with the medical defence organisations as well as the CNSGP. So as everyone will know, the Clinical Negligence Scheme for General Practice, so the CNSGP, covers all primary care services or primary care commission services, so GMS, PMS, APMS contracts. And so from their perspective, the location of the service, whether it's digital or face-to-face, doesn't affect the cover. The type of solution that you use to provide the online or video consultation is not relevant to the scope of their cover. And all of your staff, so not just GPs, but nurses, pharmacists, etc. It covers all your staff, and it covers primary medical services, both in hours and out of hours settings. But you do also need to maintain membership with your MDOs, because they cover you for things that fall outside of clinical negligence claims, so regulatory issues, for example. And again, they are supportive. They recognise this is the way that general practice is moving in, but you should. It covers NHS practice, not private practice. If you're doing this privately, then you need to get separate insurance to cover that, and also use an NHS assured solution. Perhaps COVID is a slightly strange time, but in typical times, use solutions that have been assured that meet cybersecurity and IG standards, so that you don't put yourself at untoward risk.
Thanks, Minal. Any comments on that, Mayor?
Yeah, no, this is a common reason that concerns people, but actually, Minal's provided the reassurance, and I've also checked that myself. I don't think that should be a reason why we don't embrace new ways of working. I want to make a wider point around this in terms of, we have a situation prior to pandemic where doctors were spending more time on administration than on patient care, spending less than 10 minutes with patients, a climate of burnout and fear, and we don't want to go back to that. We want to enjoy our medicine and spend more time with patients that we need to see. You know, one of my slides that I couldn't show showed that 1 in 4 GP consultations are not necessary with the GP, and 44% of administration in a GP practice can be automated now. 44%. Imagine the power of that, you know. So I don't think this is either or, nice to do. I believe we have to embrace a digital first primary care that Minal's outlined the models very clearly. You know, it's not just one thing, it's a series of things. It's got to be integrated, coherent. And actually, we sometimes make assumptions that people won't like it, or some people can't use it. It's not true. I had a 90-year-old patient that I did a consultation with who had a better phone, a smarter phone than I did, actually, and she knew about how to use it, etc. Obviously, we've got to do it sensitively. We've got to make sure that, you know, we take people with us in terms of the public and healthcare professionals. Training is available. The national framework is very clear, you know, so you have a choice of platforms and online digital tools. You know, I think we could make the working life, day-to-day life of a GP much better than it is now. As you've shown, Tariq, in your own practice, one of the leading lights of innovation and transformation. But I think it's about being a good GP, you know, safety netting, red flags, you know, do you have any questions? Are you happy with what we've discussed? And you can do that, I think. So.
And I think I would just add that this does involve working with your whole team, so it can really bring your whole team together because you're designing processes together. And it really does rely on trust within your team. And I think Ursula earlier on in the chat, you know, recognised the important role of her admin staff for these processes working. And so with HEE, we've just almost finalised a learning module for admin staff because they often get forgotten. Clinicians get all the training and the materials and not your admin staff. And so that will be available free for everybody to help train up your admin staff in ways of working. We've worked with the Practice Managers Association and lots of other practice managers and admin staff in developing this. So hopefully it will be, you know, directly relatable for them. You know, sometimes what we as doctors write, it's not quite what they need because we're not in their shoes.
Thanks, Minal, Mayor. And also, I just wanted to sort of touch on, again, socioeconomic deprivation and Black, Asian and minority ethnic groups, because it is a hot topic at the moment. And it's great that the data is showing improved access, but it's also really interesting for your own professional experiences in your own respective practices. Minal, you work in Halsden, I believe. And I know that's an area of relatively low socioeconomic deprivation. And Mayor, you're the opposite spectrum almost. You know, it's a very affluent area in Salby. I may be wrong. I've not visited actually. So Minal, how do you sell digital care to these groups, and what challenges are there to ensure access? Because the key thing here is really to reduce health inequality.
So the first thing I'd say is don't make assumptions.
One of them, of course, was about anticoagulation, because I think, you know, for all of us, oh my God, suddenly we can't run IMR clinics. There's a whole situation about how do you deliver this. So why don't we start a conversation?
Can people mute, please?
What do you also think might be good for going forward when we come out of this?
Okay. Oh dear.
Minal, we can't hear you. Sorry, I muted myself then. So I was just going to say, the first thing I've learned is don't make assumptions. So lots of my patients have smartphones and can use technology. And like Mayor said, you know, I talked at an 85-year-old lady through a video consultation just this week. So, and actually it can be really empowering for the patient as well. I think also through COVID, lots of people have learned to use technology to talk to their loved ones. So again, I think there has been lots of upskilling organically. But you're right. There's about 12 million people that don't have the skills or the connectivity to use digital in the country, and we must not exclude those. So the first thing is have routes for access for those that are non-digital users. But I think what this crisis has highlighted is that we need digital inclusion is a must. So pre-COVID, we would have reception staff with iPads that would take patients through an online consultation in the waiting room. Now, that's not possible at the moment, but that was some of the championing work that we were doing with our patients, showing them how easy it was, and actually they could do this from home, or they've got a son or a daughter or somebody who has that technology to help them, because a lot of my patients live in big families, so they do have lots of relatives around them, younger relatives, to be able to support them. Also, we've got lots of great community services. So libraries, for example, upskilling patients or supporting patients. And, there are programs like Digital Unite that are training, regular folk to become champions, digital champions, to then train others. So it could be your carer that is then training or supporting you in using this technology. So I think that be creative. I think the other thing I would say is going out to communities. So the people that are hardest to reach are always going to be hard to reach if we don't go out proactively to reach them. So we've again produced materials in languages that they're familiar with, or held events in a community setting, so not at the practice, but in the town centre, town hall, that sort of thing, and that's helped to reach a wider community of patients. I mean, I'd say that actually our population is deprived but quite young, so we've they are often quite digitally enabled, and I think I should say that we should be this, considering my role, but I think we're either the first highest or second highest user of online services in our patch.
Congratulations on that, Minal. That's a fantastic achievement.
Yeah.
So just before sorry, Mayor.
So just to say, our area is a very mixed area. I think, we assume from postcode that they're uniform, but actually within nice postcodes, there are actually pockets of deprivation and inequality. For example, care homes, for example, by diagnosis. One of my interests is end-of-life care. We know that poorer people are more likely to die in hospital. They're less likely to go in a hospice. This is generally speaking, I'm not talking about local data. But also cancer diagnosis, inequalities, they exist everywhere, But I think the most important thing I've learned from Minal is don't make assumptions. I think we have to tailor our services to our patients and give it a try. And I've been very, very surprised, actually. So I think that's keeping an open mind.
Yeah, really, really interesting to hear, Mayor of Minal. And I suppose sometimes we try and tailor so much to people from different demographics that in itself lends to inequality. So just before we have some final thoughts, I'm going to move to Kavita, who's got a 1-minute video to show us on our webinar, which is going to be talking about old age and COVID.
There's growing anger over how coronavirus has taken hold in care homes across the UK. The government suggests that 1 in 4 of the overall deaths in England have been in care homes.
Thanks, Kavita. So next week we've got Dr. Richard Wong joining us, and we're going to be talking about coronavirus in elder people. And I think there's lots to learn from the first wave as to how we implement challenges that we may foresee for the second. So any closing thoughts, Minal and Mayo? Any take-home messages from this particular presentation? There's been lots of learning for me. It's been really fantastic to learn of the fantastic work everybody is doing across the country, and also the top tips and consulting.
I think from me, I would say that this is about transformation. It's not about the deployment of technology, and it's about that quality improvement, service improvement approach. And we shouldn't underestimate the effort that requires. And so please, if you need support, you want hands-on capacity, you want the skills or the resources to help you, they are available. They are nationally funded. So probably contact Mayor if he's your CCG lead, or contact your CCG, and they can put you in touch with the teams to provide that for you. But if you're having any problems, then please email my team, Digital First Primary Care at NHS England, and we can put you in touch with your regional leads to make sure that you can access that.
Yeah.
Thank you so much, Minal. And Mayo?
I just wanted to say to everyone, thank you for what you're doing, and also to realize that this is a very big moment in medicine and in the NHS in Leicester, Leicestershire and Rutland. I think we've got a great opportunity to change the model of care. You know, there's no one who's happy with the model of care, GPs, consultants or patients. There's lots of things that could be a lot better. I know that consultants in UHL and the Partnership Trust, they want to embrace a digital first approach as well. So I think the specialist generalist interaction is also going to be very different using digital technologies. So I'd urge everyone to keep an open mind. You know, we're not going to be completely slavish to this. We know that innovation has to be applied sensitively. We have to work closely with staff and patients, you know, but I think embracing a digital first LLR will help us create a great model of care, because, you know, it ain't good at the moment. So I want everybody to help me with this.
Thanks, Mayor, and I'm sure your wise words will be heard nationally. We've had participants from London, Manchester, Preston, Birmingham and Southampton at the least this evening. So thank you so much both. There's lots of wisdom to take to our daily practice. I very much look forward to working with you all to establishing a digital first LLR community and even nationwide. Thank you, Minal. Thank you, Mayor, and we look forward to seeing you next week.
Thank you.
Thank you.
Bye-bye.
Thank you.